in and take a seat. We're going to get started. We understand there's traffic on 3 of the major highways this morning, so we had a full house registered and we're expecting some more to come in, but we also have a really packed agenda, so we need to get started or else we will fall behind, and we don't want to try to keep anyone past what we promised. So good morning.
Good morning.
That's great. I'm Alicia Woodsby. I'm the Executive Director of the Partnership for Strong Communities. We're a statewide nonprofit policy and advocacy organization dedicated to ending homelessness, expanding affordable housing, and building strong communities in Connecticut. Thank you for joining us this morning for our last IForum of the 2017 IForum series. Today's IForum will explore how Connecticut can effectively end chronic homelessness and maintain it by strengthening our homeless response system and working with mainstream systems in order to prevent it. This topic is particularly near and dear to me. As many of you know, I spent about 7 years in mental health advocacy. It's where I started my career and spent years promoting community integration and a comprehensive community mental health system for people with serious mental illness, which of course a critical and fundamental component of is safe, quality, affordable housing. Many people experiencing chronic homelessness live every day with severe disabling conditions that require supports and services in order for them to remain stably housed. When the state deinstitutionalized in the 90s, we failed to provide adequate housing, options, and services to support people with serious mental illness in their communities. As a result, many fell into homelessness and spent years cycling in and out of that homelessness. And although we have yet to really create that full comprehensive system of community-based services and supports necessary to prevent people with serious mental illness and substance use disorders from entering homelessness, we have nearly 2 decades of work at the state level, lessons learned, and progress to build on. At the start of the efforts in 2004, estimates were that Connecticut needed to address chronic homelessness, which is the long-term homelessness of people with serious disabilities, for an estimated 10,000 individuals. Fast forward to today, in the last 2 weeks when I last looked at the numbers, and there were less than 300 people statewide who were experiencing chronic homelessness, and less than 100 that hadn't been matched to a housing resource. In December of 2016, we had matched every known person experiencing chronic homelessness in the state to a permanent housing resource, a major milestone in this effort. We now have to get back to that point and figure out how to get everyone who's been verified as chronically homeless into their housing within 90 days, which is a major measure of success for this effort. To get there, it's critical that we understand the number of people who are entering homelessness from other systems, such as inpatient hospitalization and the criminal justice system. Coordinating with and using data from these systems will help us understand the need and be able to better serve people before they actually become homeless. The integration then of proven and effective housing solutions directly into these delivery systems can help us do just that. And it makes sense for these systems to do so. Chronic homelessness takes a very heavy toll on our public services. Studies show that providing supportive housing can save up to 70% of the costs otherwise incurred through emergency services, hospitals, and jails. And as many of you know, supportive housing is the combination of quality housing, rental assistance, and supportive services. It's an evidence-based practice essential to success in ending chronic homelessness. Connecticut has been nationally recognized for the innovative work that it's done for more than a decade to create permanent supportive housing. It is this stock of supportive housing that we have in the state, combined with the unprecedented leadership of the Malloy administration and the tremendous collaboration of local community providers with state, federal, and other local partners, that has really enabled us to rapidly accelerate our pace over the last few years and reach this point of progress. We look forward to a rich discussion today in advancing toward the next phase of our effort, where no one reaches the point of chronic homelessness in our state, and where our mainstream systems are the keys to that success. We want to take the opportunity to thank our program sponsors, the Connecticut Department of Housing, the Connecticut Housing Finance Authority, Webster Bank, Bank of America, and the Melville Charitable Trust. We would not be able to do this without their generous support. A lot of pages here. I also want to thank the amazing staff here at the Partnership for Strong Communities and all the work that they do to pull off all of these IForums every spring. Particularly, I want to recognize Christy Staples and Cindy Dubuque, who planned and organized today's event. I also want to thank the planning group that joined them for all their help in shaping today's program. As you know, and I say, if you've been to these IForums every time, we aim to keep these events free and open to the public. So if you'd like to donate to help us to continue to do that, there is a donation box at the door, and there are staff all over who will be happy to help you figure out how to do so. And we will be live tweeting this event at PSC Housing and hashtag IForum17, so please follow along. Lastly, we ask that you please save your questions until our question and answer period. We'll have staff on the floor with microphones at that point, and we'll welcome any questions at that time. They'll be there after both the presentations and the panel discussion.
Fantastic.
It is now my pleasure to introduce two leaders who have played fundamental roles in the state's progress in ending chronic homelessness. Haven't quite ended it yet. The departments that they lead, Department of Housing and Department of Mental Health and Addiction Services, have modeled the effectiveness of collaboration, especially through the creation and delivery of supportive housing, which requires an affordable housing unit, DOH, combined with wraparound support services, DEANS. They have been creative, flexible, and solutions-focused in our statewide efforts to end homelessness, and are critical partners in our work moving forward to prevent future chronic homelessness. Yvonne M. Klein is the Commissioner of the Connecticut Department of Housing, the lead state agency on housing matters. The department provides a wide array of funding programs and services aimed at ending homelessness, increasing the supply of affordable housing, and creating new home ownership opportunities for Connecticut residents. Under her leadership, the department has expanded its development as well as individual and family support programs and dramatically increased the state's investment in affordable housing. Miriam Delphin-Rittman is the Commissioner of the Connecticut Department of Mental Health and Addiction Services. Prior to her appointment, she held varied positions at the department, including Deputy Commissioner, Senior Policy Advisor, and Director of the Office of Multicultural Healthcare Quality. Under the Obama administration, Dr. Delphin-Rittman served as Senior Advisor at the Substance Abuse and Mental Health Services Administration with the Department of Health and Human Services, working on a range of policy initiatives addressing behavioral health equity, workforce development, and healthcare reform. Dr. Delphin-Rittman has also held positions as Assistant Professor and Director of Health Equity and Multicultural Research and Consultation, mouthful, with the Program for Recovery and Community Health in the Yale Department of Psychiatry. Please join me in welcoming them to the stage.
Good morning, everyone. It's great to be here. And thank you, Alicia, for inviting us to be here. And I can't think of a better way to sort of end this IForum series, right? Wrapping up and really looking ahead. So I think it's been a very successful series, and I'm proud to say that we've been a part of them. And thank you for your leadership, and thank you for allowing us to be a part of this. So we're fortunate in Connecticut to have a governor who is committed to preserving, rehabilitating, and creating affordable housing, and who has demonstrated his leadership in preventing and ending homelessness. We are also fortunate under the Malloy administration to have broken down the silos of state government, and we have an invaluable partner in the Commissioner of the Department of Mental Health and Addictive Services, Commissioner Delphin-Rittman. So I thank you for your partnership. She's here. I thank you for your partnership and support. We couldn't do incredible successes during the past, I would say, 4 years, 5 years, 6 years. We were the first state in the nation to end chronic veteran homelessness. This was no small feat, and none of us did it alone. And we did it with a great deal of support and hard work on the ground, so thank you for your hard work. And we're only one of 3 states to have ended veteran homelessness. And we're the only state in the nation to have set a goal to match every chronically homeless individual with housing. And we achieved that goal by the end of 2016. So thank you for that. So it was an ambitious goal, and we got there. Now, I don't have too much of an issue with the federal benchmark because what I know in Connecticut is when we set our goals and we've built our system with the incredible talent that we have, I know that we're able to accomplish whatever we set out to do. And I see nodding heads in the audience, and I thank you for all of that. So we're a state of firsts, and we're proud of that. And we're making our mark, and we're leading the country in the housing arena, which you are all very well aware of. It's no secret that Connecticut is facing tough economic times, and that's why, more than ever, it's so important to come together to ensure all of our systems are finely tuned. Today's IForum will focus on how we can take the system we built together and ensure its continuity for the future. We're ending homelessness in Connecticut, but as you know, that does not mean that we will never again have an individual who is chronically homeless or homeless veterans. It means that we have an established system in place that can easily and quickly identify these individuals and rapidly match them to housing. So maintenance and improvement is the key to our future and our success. Preventing and ending homelessness is a laudable accomplishment and one worthy of much attention. Preventing and ending homelessness just doesn't make good economic sense, and I think these days we're hearing a lot about economic sense, right? And the focus has been strictly financial. But in my mind, in my heart, it's more important that the long-standing individual and social impact is far more important. So we know ending and preventing homelessness is good for the economy. It's good locally for the economy. But as I always say, it's most important. It is the right thing to do. So that's why it's so important now more than ever that we're taking the time to talk about our system, talking to our friends and our colleagues, talking to our state and federal legislators, talking to local newspapers. What we know is that on average it costs the state almost $33,000 a year in services to assist an individual experiencing homelessness. That number drastically increases to over $120,000 a year when the state needs to provide services to a family experiencing homelessness. Likewise, it only costs the state about $10,000 a year and about $15,000 a year to provide permanent housing to an individual and a family. The cost savings is certainly a no-brainer, and it's something that we should be investing in. But when we talk about our investments, it's not just about the next 2 years, it's about 2 decades. Homelessness is expensive, and having an established system in place that is designed to rapidly identify and house homeless individuals and families is key to a strong economic climate. And not forgetting how transformative it is to an individual and family when they have a permanent, safe, secure, and affordable home. Our network of housing providers in Connecticut is next to none. We brought together stakeholders at every level of government, federal, state, and local. We have nonprofit housing providers and coordinators in the private and philanthropic sector all coming together. So working together in close collaboration to bring about an end to homelessness in Connecticut. Of course, this fine-tuned system is just one of the many resources we have available in our great state. Were it not for the strong pipeline of affordable housing that has been created under the Malloy administration, we would not be able to provide permanent housing to those in need. Since 2011, together with the Connecticut Housing Finance Authority, we have created, preserved, or rehabilitated 10,700 units of housing. We have another 4,100 housing units under construction, and funding commitments are in place for another 5,200 units of housing. Altogether, this amounts to an investment of more than $1 billion, and a strategic investment at that, because the matched investment we've seen from the private sector and other sources is almost $2.5 billion. Of these 20,000 units of housing we've played a role in funding, the vast majority of them have affordable deed restrictions on them. Our system of coordinated access is working, and it's an essential piece of the puzzle as we continue to make progress, real progress, in ending homelessness and growing our affordable housing stock. I'm proud to be a part of this administration, and I'm proud to serve under such a forward-thinking leader. Governor Malloy's vision is one that I know the people in this room feel quite strongly about. So thank you for your commitment to his vision and the work that you're doing. And as I always like to say, together we are building a Connecticut where everyone will have a place to call home. Thank you.
Good morning, everyone. It's wonderful to see many familiar faces here. We often say that ending chronic homelessness takes a village, and really everyone in this room is part of the village. Each of you is committed to this work through the work that you do, and so I thank you for your presence. I thank you for being here and for your commitment to ending chronic homelessness. I'd also like to thank Commissioner Klein for our partnership. The work that you all do is just really tremendous. Department of Housing, the partnership, and all other partners throughout the state who've made ending chronic homelessness a reality here in Connecticut. As I was looking over my remarks this morning, I remember that my early work started as a case manager in New York City. This was in the 80s, so I guess I'm dating myself a little bit, but I remember some of our conversations saying that, will we ever get there as a country? Will we ever get to a place where we've ended homelessness? And I have to say, I'm honored and proud to be commissioner here in Connecticut and to be one of the first states that's sort of hit this benchmark. This is significant. This is a big deal. Housing, we know, is an important part of helping an individual achieve and move into long-term recovery. And so the work that you've done to help all of us, working together reach this benchmark really is significant. We all know, again, that ending chronic homelessness in our state is no simple feat. It's required the leadership of our forward-thinking governor and other state leaders, the collaboration of a number of state agencies, nonprofits, the private sector, and the dedication of our private nonprofit providers and housing coordinators who work tirelessly, to connect people to the necessary supports and resources so they can transition into their new homes. And while being the first in the nation to connect people who are chronically homeless to housing is remarkable, it's a remarkable accomplishment, our work does not end here. It's imperative that we do what we can to keep people permanently housed and to prevent those that we connect to housing from falling into homelessness again. As Commissioner of the Department of Mental Health and Addiction Services, I can tell you that one of the greatest risk factors that contributes to homelessness is a person having mental illness or substance use disorders that goes untreated. We know that the rate of mental illness among people who are homeless is twice that, the general population. When working with people who have severe mental illness, we also know that providing them with housing, while important, is not enough. Stable housing provides a set location where people can regularly get services and supports to help them sustain their recovery. And when a person achieves success in recovery, they're more likely to be engaged as a citizen within their communities of choice, living up to their maximum potential. And while getting people housed is half the battle, the other half of the battle is helping them remain housed. Supportive housing programs also provide community-based services that help tenants with basic skills of tenancy, like budgeting, mediation with landlords, and connecting people to subsidies that may be eligible for. What's important is that in our state, we now have a system in place that identifies people who are chronically homeless, so that if they do fall on hard times, we are able to quickly connect them to the supports and services they need to become housed again. And getting people housed quickly quickly means that they're more likely to access treatment services and supports so that they, again, can move forward in their recovery. Demas provides housing services and supports to about 3,700 people statewide. Programs like our supportive housing program not only provide housing supports to help keep people housed, but also connects them to mental health services and gets them treatment and support so that they can progress. I often hear stories about, for example, like a woman who was homeless for 20 years. Over 2 decades she lived on the streets. The woman would cycle in and out of the hospital, ERs, nursing services, because being homeless, she lacked the stability she needed to connect to services and supports to help her physical and mental well-being. Thanks to supportive housing, she not only has a place to call home, but she's now connected to services and supports that help her get whatever treatment and other support she needs, both in terms of physical and mental health. The coordination and integration of care offered through supportive housing and the connection of clinical and medical care she's now able to receive has allowed her to remain in her home and stable for 3 years now, helping her to stay healthy and out of the emergency room and receive the medical care that she needs. It's success stories like these that show how programs like supportive housing help people in their recovery, help them to stay physically and mentally well, and help them to reach their maximum potential while living in their communities of choice. They are a testament to the fact that our efforts to provide housing to those experiencing homelessness and providing supports and services to address their physical and mental health issues can help people and provide them with the stability to move into long-term recovery. So once again, I thank you for all that you've done, for your commitment and dedication to ending chronic homelessness. Our work is not over by any means, but we know together, working in partnership, we can continue to make ending homelessness a thing of the past. Thank you again for being here, and thank you for your commitment to this important.
I want to thank the commissioners again. We're so lucky to have such strong leadership here in Connecticut. Another thing we're really lucky to have in Connecticut is a very strong, often not thought of partner, which is philanthropy. And so I did mention when I talked about state and federal and local and community providers that we also have really strong philanthropic partners here in Connecticut. The Melville Charitable Trust is the large statewide funder of homelessness efforts, but also just a tremendous amount of local community providers and other state level funders who are coming together to contribute to this effort and to say, we see the systems transformation that's happening. We want to support that. We want to support collaboration and coordination and systems transformation. And so it would be remiss if I didn't mention that as well. I now have the pleasure of introducing our keynote speaker, Terry Power. Terry has 26 years of experience in providing and supervising high-quality services in a variety of social service settings, working with families, youth, and single adults. As a senior program manager for CSH's, the Corporation for Supportive Housing, their Ohio office, she monitors, manages, and expands the statewide reentry supportive housing project, Returning Home Ohio. In addition, Terry provides technical assistance and training in services on services in supportive housing, Medicaid, and quality improvement practices. Prior to joining CSH, Terry directed services across multiple cities in Ohio in family permanent supportive housing, single adult transitional housing and emergency shelters, and correctional halfway house programs. So please join me in welcoming Terry Power.
Thank you, everyone. Thank you for inviting me. I'm really excited to be here. I love talking about returning home, so this is great. I want to congratulate your state on your ending chronic homelessness and all the progress that you've made with homelessness in general and veterans homelessness. So really, really great job. It's wonderful to hear that. You should be very proud of that. So I am from CSH. We go by CSH. No one remembers Corporation for Supportive Housing. It's kind of long, so CSH works. We are a housing organization that promotes supportive housing to impact the lives of vulnerable populations. Early on, we also concentrated on ending chronic homelessness, but because I think as a country we are moving toward that, CSH is also looking more upstream, as we call it, to populations that may end up homeless that we would like to prevent. And working in the criminal justice system is one of those areas. That's what I'm going to talk about today. We also work with those impacted by long-term institutions and nursing home stays as well throughout the country. So that's who we are. I think a lot of you should already be familiar with us. So I'm going to talk about returning home. Returning Home is a permanent supportive housing program for offenders leaving state prison just from state prison. I know in Connecticut, jails and prisons are one entity. In the state of Ohio, they're separate. So we only work with state prisons. There's probably 25 prisons across the state. So Ohio's a lot bigger than Connecticut, obviously. And we have about 196 units across the state. So I'm going to talk about that, but I just wanted to set the stage in case anyone was like, what the heck is returning home? So in the beginning, when it started in 2007, we had to make the case. And it wasn't that hard of a sell, as you might think. The state of Ohio, we are actually one of, I think, 2 state departments of corrections that actually still has rehabilitation in their name. So we are the Department of Rehabilitation and Correction. So Ohio has always been visionary and progressive when it comes to rehabilitation. The sale of supportive housing was a little bit much, and that's where I think we had to make the case for cost, for access to shelters. We looked at Dennis Culhane, as I'm sure many of you know, his work, and just looked at some studies. One study from New York State Prison noticed that 12% of offenders that were released into New York City returned to shelter within 2 years, and half of them within the first couple of months. It also showed that when you were in shelter before becoming incarcerated, you were more likely to return to shelter and homelessness after incarceration. And I think we all know if you return to homelessness or shelter after incarceration, the chances of you cycling through the system and getting reincarcerated again is much, much higher. And of course, the cost of prison is far more than the cost of someone in supportive housing. I think in the state of Ohio, and this was several years ago, the cost of incarceration annually was $25,000 to $30,000, which is almost double, actually probably more than double, what it costs to house someone in supportive housing for a year. So one of the areas that we were able to look at in the state of Ohio was what our Department of Rehabilitation and Corrections called the transitional housing gap. So they realized there were offenders that were leaving that were not being accepted into halfway houses and transitional housing programs. There were also those that were graduating from halfway houses who were still ending up homeless. And so they were really concerned about that gap, and those were the people that were entering incarceration again. So they looked at that. Who are these people? And they were those that had a severe and persistent mental illness. They were those that had a sex offense. They were those that had a huge history of years of incarceration. So there was this group of very difficult to serve people that were not being helped by the halfway house and transitional housing programs. In addition, they wanted something that was data-driven, and as someone mentioned earlier, early on so eloquently, permanent supportive housing is shown to be very effective in ending homelessness and working with the homeless population and chronic homelessness. It's been studied for 20 years. It is a best practice. It does combine quality, affordable housing with services. Returning home follows that model. It is not just housing and it is not just services. It is the combination of both. And our department believed in that. They knew that that was important if they really wanted to break that cycle of incarceration. And it was a system-wide collaboration. So in the end, as you'll hear, our Department of Rehabilitations, I'll just call them DRC, did in fact fund returning home at 100%, and they still do. However, in the beginning, our Department of Mental Health and Addiction Services and our Housing Authority really were key in identifying who is it we need to serve, where are these people, and are they in the shelters. And so in the beginning, we really did have a great collaboration and a collaborative system. And we still work very well with the Department of Mental Health and Addiction Services in terms of identifying need, especially in expanding. They really assist us in where are these offenders going to, and how many of them do have a mental illness because they track that. So that's helpful. So in the beginning, the design, it was in 2007. I didn't work for CSH back then, but it was decided that the Department of Rehabilitation and Corrections was not going to be the one who was going to oversee this project. They did, in fact, I'm not sure how people get placed in halfway houses in Connecticut, but in the state of Ohio, they go through our Bureau of Community Sanctions. So we have an entire bureau that maintains the referral wait list and doesn't necessarily approve, but manages the referrals that go from prisons to halfway houses, CRCs, and other places. They decided that it was really important for someone who understood supportive housing, who could manage the quality, to take that on. They were involved in the referral process during that 5-year pilot, but they did decide CSH was going to manage it. So that was one of the designs early on. They also decided that it should be a pilot and that it was going to be studied. And part of the money that we received from DRC in the beginning did go toward the evaluation study. It was done by the Urban Institute. I'm going to talk a little bit about that a little bit later, but that was decided upon very early on. It made everyone feel more comfortable, including CSH. I don't think any of us want to do anything that's not effective and that doesn't work. So we were thrilled that we were able to get something studied right from the beginning and see what the effectiveness was. So that was a win-win for everyone. It was also decided that we would work with 10 prisons instead of I think, how many there are. I think it was easier for the Urban Institute to manage that. They studied, I'm only going to talk a little bit about the outcome results of the study, but they also studied the process. So they studied the referral process and how that happened, and when the offenders went from prison into housing, and if they couldn't go straight into housing, what impact that had. And I'm sure that we could provide you with the 50-page summary if you are all interested. It's really very interesting. But so they did study the process too, and so that's why I think they decided on the 10 prisons. I'm not sure how they decided on the prisons they decided. If there was maybe more inmates that had disabilities in those prisons, I'm not sure. Also, in the design phase, it was decided that disability was going to be very broadly defined. It wasn't just those with a severe and persistent mental illness. It included really all kinds of disabilities. I'm not sure anyone was excluded based on disability. It included physical disability, cognitive disability, many, many things. It changed after the pilot was over, but during that time, disability was very broadly defined. And I'm not sure I mentioned, the pilot started July of 2007, went through June of 2012. And it was a pilot and study for those 5 years. So they launched it. There was a lot of education and training that CSH needed to do during that launch phase within those 10 prisons. prison staff, DRC staff did not speak housing. Housing did not speak corrections, as I'm sure you all know. So there was a lot of cross-training that needed to be done. And I encourage you, whenever you talk to anyone that's outside your field, and I'm sure hopefully you hear this advice, do not use acronyms, do not assume anyone knows what you mean by words that you know what they mean and they don't know what they mean, and vice versa. If someone's speaking their language, make sure you ask the questions and don't think that you know. I've left a meeting with people saying the word assessment, and I come from a clinical background. They meant something totally different by assessment that I thought they meant, and kind of skewed the entire conversation. So always make sure you understand what they're saying. Make sure that you make yourself really clear. So there's a lot of lessons learned on that. Very, very important. They decided on specific grantees. So again, DRC said, you, CSH, are going to manage this. We're going to give you the money. So they gave the money, and they still do it this way, up front. Our program year runs from July to June, somewhere between July 1st and August 30th. We receive the money, and then that really allows us the flexibility to then grant money or award money to the grantees based on occupancy, performance, all of those things. And that's how it started. So between the housing providers that CSH knew were reputable and the providers that DRC knew that knew corrections, that's how they decided upon those first few grantees in that first year. And the training and education and outreach really continues to this day, but that was a large part of the launch. And then obviously the implementation, it was, again, in-reach into the prisons, making sure the case managers understood the program, how to make the referral. In those first 5 years, the referrals did go through DRC. They knew that, they understood that process, so we continued that process. And then the DRC staff sent it to CSH, who then sent it on. We don't do that anymore. That was a pretty cumbersome process, but it allowed some control over that, especially during the evaluation study. There was a lot of mixed reviews, I think, from DRC staff. Some thought it was great and really needed, and others felt like, we're paying for housing forever? What? So again, it took a lot of education about what it meant, and really dispelling a lot of myths out there. So our role, I'm going to talk a little bit about our role, because I do believe, not just because we're CSH and we're managing it, but I do believe that if there was no driver and was no manager over this program, it would not be as successful as it is. It would not be statewide. It may have even fizzled out, I'm not sure. But I honestly believe that it's very important that there is a driver or a manager of the program that understands supportive housing. So we started with about $1 million, I think, and I think I've read some different numbers, but it was somewhere between 85 and 95 units throughout the state. And in those 5 years, they stayed pretty steady because it was a pilot. They didn't want to change too much. We did get a little bit more money here and there, but we now have over $2 million, and we're almost at 200 units throughout the state with 10 grantees. And again, the Department of Mental Health and Addiction Services helps us when we get additional money to expand. So where should we expand? We put out RFPs and really vet the agencies that are going to join our program. So we manage and administer the awards. We monitor occupancy, we monitor performance. I'm going to talk a little bit about our outcomes later, and we monitor those. We continue to do in-reach into the prisons. We are now, after the pilot ended, we are open to all and any prison. We have targeted our in-reach to those prisons that have the most inmates, that have the highest number of mental health offenders. So that helps, because when you're doing in-reach across the state of Ohio to 25 prisons, it can get a little costly and a little time-consuming. We actually hired a second person to assist in returning home in the program, so because it got unwieldy. But it's constant. I'm sure you experience the amount of turnover that happens in the Department of Corrections. So there's always new case managers. They have a lot to do. There's a lot of offenders. They forget. So literally we visit those targeted prisons every year, at least once. We join their case management meetings, so we don't ask them to just meet with us separately. We do it at their convenience. And then just really talk about the program all over again. We also, on the grantee side, provide training and technical assistance to all the providers. We have meetings, we have trainings. As I always say to our grantees, you have a foot in two worlds. You have a foot in the corrections world and you have a foot in the housing world, and you need to understand both of them. So sometimes our trainings are about supportive housing. Sometimes our trainings are about dealing with the corrections population and criminogenic needs and how to work with that. The state of Ohio, the University of Cincinnati has a corrections institute. We're very fortunate. They've done tons of research on working with the criminal justice population, so we have to include them as well. So CSH manages all of that. Then we, of course, report to our DRC on a quarterly basis. Information about occupancy, recidivism, housing stability, referrals, where they go, how many referrals we accepted, and all of that kind of thing. So I want to talk a little bit about the referral process. We, in the beginning, they all did go through the Department of Rehab and Corrections, and then they sent them to CSH, and then we sent them to the grantees. At the end of 2012, when the pilot ended, we decided to take DRC out of the middle, and we actually took CSH out of the middle also. We have a returning home directory that we send every time we go to the prisons, and we send it out probably 3 times a year just to make sure people remember. And the referrals go directly to the grantee, to the provider, and they make the decision. We have a special email that we can monitor the rejections. So when a provider rejects a referral, they are supposed to give a reason, and then we can track that. But it goes directly to, so we're actually all out of the mix. And it's much smoother. So the original research results in the comparison group and the treatment group, originally they wanted to follow them for 2 years, but they could only follow them for 1 because they couldn't find a significant enough number in the control group. But 60% of the returning home Ohio group were less likely to recidivate back to prison, 40% less likely to be rearrested. They received almost 300% more services, and they were 41% more likely to receive at least 1 service. And they received services much quicker, so that gap of not having any service was a lot less, and I think they engaged more. It was thought of as cost neutral because the cost did move from criminal justice to health and Medicaid, so those services were looked at through Medicaid billings. But everyone around the table, all of the state departments, really felt like it was much more appropriate for this population to be treated through health than through criminal justice. So everyone was really pleased with that, with those results. So I think I talked a little bit about this. Our grant is approximately $2.2 million. We have just under 200 units. Each grantee develops its own budget, so we're not really prescriptive about the budget. Your budget, you're allowed to look at what you feel like you need. It also depends on the number of units. So obviously it's a lot more expensive for people who only have, agencies who only have 10 or 12 units than agencies who might have 20 or 25. It's, in terms of cost effectiveness. So we allow every provider to develop their own budget. And we also do not prescribe who they can and can't take. So we don't force anyone to take sex offenders or arsonists or those difficult to place offenders, because I don't want anyone working outside of their scope. And I think I talked about CSH's management. So we did our own little study. This was not, there was no control group, there was no anything. I was just really curious. July 1st, 2012, we were not a pilot anymore. We became an ongoing program at DRC. We became part of their placement options, which is great because we're now permanent in their budget. which was wonderful. So we just did our own little study, and we only looked at those that returned to prison because we really don't have access to all that jail pop. There's no one database for all the jails across the state, so we just really only returned to prison. We served 368 people between July 1st, 2012, June 30th, 2016. So it looked at that period of time. And including the people who were still in the program and the people who left the program, 12% of those returned to prison. Then we just looked at the people who left, just the discharges. And same 45. The N is smaller because only 210 people have been discharged, and it was 21% of them. And most of it was parole violations, unfortunately, even with us advocating for them. It was very disappointing. And so I think I talked a little bit already about the key, these kinds of things. I think if anyone's interested, maybe we can get at that through questions. I think I skipped, hold on. I think I skipped a slide. Nope, I must have done the slide later on. So let me just say quickly, we track our own outcomes on a quarterly basis, and I just wanted to review with those what they were. I must have added that slide later because it's online. Of course. So we track income, employment, public benefits, so who's on benefits. We track what we call other meaningful activities, which is things that are not related to service, so it doesn't include case management, counseling, medication, but it's just really community involvement. We spend a long time defining that for the providers, but we do that, and actually they're doing pretty well. Successful housing outcomes, we include those who move on to independent housing, those few who move on to another subsidy, those who move to maybe a family or a friend. We do get some that move to a higher level of care. So those are all what we would call successful discharges. We also monitor voluntary services, so not the case management, so not the returning home Ohio case manager that goes into the home, but other services. We probably struggle the biggest with employment. I think that's the one that we have that we're the least, and our goal is only 30%. Because, so one of the things I forgot to mention was when the pilot ended, we formed a work group and changed the target population to only those with a severe and persistent mental illness. We probably serve probably more than half are dual diagnosed with substance use disorder, but we do not accept substance use disorder as a primary diagnosis. So that changed a little bit of the dynamic. So everyone has a severe and persistent mental illness. So our employment goal is low. And our income, we're not really meeting our income goal either, so we need to be a little better about helping with Social Security benefits and those kinds of things. So, one thing I did want to mention, during the pilot, we had joint meetings, which helped, between DRC and returning home providers. It allowed them to meet each other, it allowed them to ask questions, network with each other. It enhanced the flow of information and communication back and forth. I think that was a really good thing. We continued that when I got to CSH in 2012. Last year, I discontinued it because I felt that the returning home providers didn't get a chance to talk to each other, and they needed a lot of training. As you all know, the people we work with are very, very challenging. You have a history of incarceration, you have a history of mental illness, you really need a lot of assistance in reintegrating into the community. And I think that they've appreciated learning from each other. So we did stop those meetings. We probably could have a joint meeting maybe once a year, but we still have quarterly meetings with the returning home grantees, and I think they really appreciate the team that we've built through those meetings. I raced through. So, yeah, so I just presented. I'm not sure what you're actually more interested in or less interested in, so I'm happy to answer questions.
So if anyone has questions, we have a mic for you. Anyone?
Not surprised to well, yeah, I'm curious. When we talk about permanent supportive housing, can you help us understand what that means to you?
Yes.
And then those successful discharges, what that looks like, so that how is that system churning?
So thank you for asking that question, because I was going to talk about moving on, and then it got a little complicated, so I appreciate you asking that. About maybe 2 years into the program, DRC became a little uncomfortable with the whole non-time limited. So in the beginning, they talked a lot about time limits, and CSH said, if you want us involved, we're not going to do that. That's not what we do. We don't do transitional housing. And so they were okay with it for a few years, and then they came back to it and said, yeah, we're still not comfortable. So what we did is we compromised, and we formed a moving on work group where we have an assessment that we use. It's called the Tenant Status Evaluation. I'd be happy to give the partnership copies of that if you're interested. We do it. We're just revising it, actually, just now, right this minute, for July 1st. We're making it a little bit easier to understand so that it's consistently implemented across the board. So we do that at 12 months, when someone enters housing, so 12 months after that, and then every 6 months. And it looks at every domain. It looks like at housing, finance, mental health and substance use crises, your life skills, your community support, your ability to engage community support, so your income, employment. It looks at all of those domains, and then there's a score at the end. DRC was comfortable with that. They said, okay, this is a great compromise. If you're willing to do this and move people on when they're ready, or validate the need for them to continue in the program, we're good with that. So we have been doing that. Our length of stay is about 16 to 18 months, which is pretty short. And I think as long as we stay there, they're not going to ask any questions. I actually think it's a little too short for me. I'm a little uncomfortable with that. When we looked at those outcomes that I just showed you, there were, I think I wrote it down, the percent of them that had only stayed with us for 6 months or less. It was pretty high. I think it was 30% of those negative discharges, or those that returned to prison, that were with us 6 months or less. So clearly, it's those people that don't engage, obviously, that we have the hardest time. So it told us a couple of things. We need to engage immediately, and we need to be able to keep them engaged for a longer period of time.
I was just wondering, in permanent supportive housing, services are usually voluntary, but you mentioned that other services were voluntary, but that the services attached to the program, they go in the home. Are they required to engage in those services, or is that also voluntary?
So case management, every grantee has a case manager, at least one, depending on. We try to keep the caseload to 15 to 20 per case manager. Not quite the Housing First model, but it's about the best we can do. So they must allow the case manager, they have to see the case manager, the returning home case manager. We like them to go into their unit. And I think I've heard of one person in the 360 that we've served that wouldn't allow anyone in their unit for like ever. I mean, so normally we can figure our way in. So they do need to see the returning home case manager. Medication, counseling, all those kinds of things are voluntary. And then we have the other meaningful activities. And I think they use the fact that they're being measured on it, that it's a goal for them to try to encourage the client to do it. And we have a sheet that the client actually fills out. So some of them really take ownership. Look what I did, this week. And so we find that we think it's connected to housing stability and reintegration.
Great, we have time for one more question.
Thank you very much. The results are very impressive. Quick question, well, two questions actually. What's the gender breakdown of the population served? And assuming that many individuals are parents, is the Child Welfare Agency part of the cross, system collaboration? And how's that, worked out in terms of reunification or at least some kind of relationship with children?
I don't have the gender breakdown. I'm going to say when I first started, we probably had maybe 10% women. I'm going to say now it's probably closer to 20 or 25. And we probably have, of our current 200 people, we probably have 5 that have their kids. So it's not a big, but we do take them, and we do work with child welfare because obviously their children are not in their custody. So they need a bigger unit, and there's a lot more collaboration that goes on, but it's not a high proportion of our clients. A lot of those discharges too, we've discovered, were individuals that had drug issues, and their lease violations or reasons for discharge or recidivism had something to do with a drug-related issue, whether it was behavior, violence, the apartment, or just actually possession. So that's a problem, obviously. We're being impacted by the opioid crisis as well.
Thank you so much,
Thank
Terry.
you. Thank you.
Good morning. I think my mic's on. Am I good?
Yes.
All right, thanks. I'm David Gonzalez-Rice. I'm with the Connecticut Coalition to End Homelessness. I've been working in Southeast Connecticut for the last 3 years. I was previously at the New London Homeless Hospitality Center, working in permanent supportive housing, and as part of our CAN process, I was very involved in our 2016 initiative to end chronic homelessness. So I can say anecdotally from my involvement as a provider in that initiative, as I'm sure many of you experienced, that many of the folks we were serving had significant engagement in criminal justice and health systems. We often found that when we matched somebody to a housing resource in our matching meeting, that they had a court date coming up within the next couple of weeks. And it was great to be able to send the case manager along to advocate. So I'm really pleased today to have a panel that the partnership has assembled of experts in cross-sector collaboration. We have a number of individuals who have served the same population we're serving and have thought about identifying risk factors for homelessness and chronic homelessness from perspectives of their respective systems. So thanks to the partnership for inviting me to moderate, and I'll introduce our panelists. We have, I'm going to be going to this mic. Great. How's that? So-so, samey. I can talk louder. All right. I'll keep going and let me know when the sound kicks in. Oh, I'm getting a thumbs up in the back. Great. Thanks so much. So we have Kevin Kane is our Chief State's Attorney. Why don't you file up as I introduce you? Seems like as good a way to go. Then at least you'll be sitting in the order I introduced you. So Kevin Kane has a long career as a prosecutor for the state, and now is an innovator in diversion especially, overseeing all prosecution across the state of Connecticut. Thanks for being here with us today. We have Dr. Kathleen Maurer. She's Director of Health and Addiction Services and the Medical Director for the Connecticut Department of Corrections. Long career as a hands-on clinical care provider, and has been prioritizing within the institution, bringing in treatment for substance abuse disorders, hepatitis C patients, and other innovative initiatives. We have Kathy Flaherty, who's the Executive Director of the Connecticut Legal Rights Project. Kathy, thanks. She's worked for many years as a staff attorney for the statewide legal services of CT, and her agency is tasked with providing legal services to low-income persons living with mental health conditions in our state. So thank you, Kathy, for being here today. And Fred Morton from Demas. Hi, Fred. I like this game show feeling. I like this. Fred works out of Demas. Many of us know him from our permanent supportive housing projects, and we're glad to have him here with us today. We have Stacy Pete. Hi, Stacy. Stacy works as a high-risk navigator in the Norwalk Hospital system. She's been doing that since 2013 and has been involved in New York City nonprofit initiatives targeting high-frequency users of services there as well. So I'm glad to have her with us to speak to community care teams. And Steve DeLilla from our Department of Housing, known to all of us. Steve's work has been so crucial to prioritizing housing first and harm reduction in all of our state-funded homelessness and housing programs, and of course serves us at the CT Boss as well. So thanks everybody. If you take a seat, we'll go to some questions and have some time for Q&A. Turn this around to face you. How's my sound? We're good? Yes, no, kind of all over the map. You know this mic works. Hello? No? It's just me. It's not the sound, it's just me. All right. Well, we'll see how this goes. So first to Dr. Maurer. You've been part of the treatment program Pathway initiative in Bridgeport. There's a lot of information about that initiative in your packets for those of you in the audience. We did want to ask Dr. Maurer and a couple of our other panelists to speak a little bit to the initiatives they've been involved in that may be less familiar to our audience, which we know traditionally is focused on housing. How's that? Is that this mic? Thank you. Okay, so if you could say a little bit about that project, thanks.
Yeah, thank you very much. So we, a little over 2 years ago, we started something called the treatment program Pathway. And the whole point of this was, I'm kind of a little sick and tired of putting people in prison because they're sick, right? Which we do a lot, especially with substance use disorders. And this guy here to my left, he's kind of feels that way too. I'm not going to speak for him. I'm not going to speak for him, but I will say that Kevin Kane and I got together and said we have to do something about this because I can't do a real good job caring for all the people who come into my system who have substance use disorders. I don't have enough services, and I have really sick people, right? So 80% of my population has a substance use disorder that requires treatment. Think about that, 4 out of 5. We have about 15,000 people in our system right now, jails and prisons. So the important thing is that there's a whole group of people who probably should not go to prison or jail, who really should be diverted to treatment. So Kevin and I sat down, along with his kind of point man, Brian Austin, who's here today, what a great thing to see him, and said, let's figure out how to do this. And so they really did the work. I mean, this is, you know, Commissioner Delphin-Rittman said it takes a village. It takes a couple villages, actually, to do this kind of stuff. So we went down, we talked to prosecutors. The prosecutor said, I don't know about this. And then toward the end of the session, a bunch of the junior prosecutors stepped up and said, you know something, this is a terrible problem for us. We have people who have substance use disorders and mental health disorders who come into jail all the time. We treat, you know, we send them to keep them in jail or send them to prison, and then they're back in a month or two. We do nothing for them. And so actually it was just obviously an idea that was ready for people because the prosecutors were even supportive. The public defenders got on board, and we started this program. So what does it do? It runs through the conventional method for assessing patients. It's not a big, expensive add-on or anything else. The bail commissioners, who see every person who comes into the courthouse anyway and assesses them for risk, for a variety of different things, and make a decision about bail, which they offer to the court. They also assess these patients looking at potential for diversion. And in order to divert for our program, you have to have a substance use disorder, usually either opioids and or alcohol, but now any substance use disorder it qualifies. And they have to be nonviolent patients, did not commit a crime with a gun, and are potentially treatable in a community service treatment provider that we selected. And we went to Bridgeport to do this because we knew we had a really strong community service provider there, Recovery Network of Programs, and we run that program every day. So people are assessed, they're in the courthouse, they're assessed by a licensed clinical social worker and receive a full biopsychosocial assessment. Then if they are approved for treatment or acceptable for treatment, and if they want treatment, that their case is presented to the judge. And the judge decides if the person is appropriate for diversion or not, and that's how it works. So in the last 2 years, we've screened, so the basic bail commissioner screening, about 700 people. We have, I think, diverted 250, something like that, 225 to 250. And out of that, we typically have about a 65% success rate, meaning they finish their treatment and they do not get reincarcerated or rearrested. So that's how the program works. And we were lucky originally, early on, to get funding from the Public Welfare Foundation. And also we got some technical support from a national organization called TASK, Treatment Alternatives for Safer Communities. After the first year, this program was able to succeed without additional funding. So it is a fairly effectively self-sustaining program. And what it does is, instead of putting people, prison and jail, either one, are extremely challenging for human beings. And I don't care if you have no medical problems or if you have serious mental illness or serious substance use disorders. They are both extremely disorienting and disorganizing for people. And if we can do something for people who have low-level nonviolent crimes, to direct them into treatment, not into punishment, because they need treatment, they don't need punishment, then in my opinion, we're way ahead of the game.
So just to follow up on that a little bit, so what you described is brought to that scale in Bridgeport, really. And I know that you and Attorney Kane are working on efforts to port that model elsewhere or to think about how it could pattern things across the state. I wonder if, Kevin Kane, you might speak to, you've been looking at different kinds of diversion initiatives across the state of Connecticut. What in your mind makes for a really effective diversion initiative? In what time frame does your system want to intervene to prevent someone from coming into greater contact with the criminal justice system?
I think this is one of the big issues that we have to face right now today. We've spent a lot of attention over the last 4, 5, 6, 7, 8 years looking at the back end of the system, looking at recognizing that we're spending an awful lot of money on prisons, and that's motivated a lot of people to want to close a prison and get people out of the prison and save money there. And that's led to looking at what we can do with these people who are coming out. What's happened is we haven't paid sufficient attention to the front end of the system, to the very beginning of the system, pre-arrest and pre-police. And when I hear Kathy talk about how she's tired of seeing so many people go to prison, I've been a prosecutor now for 45 years, and some people we've been putting into prison for many years, and I'm getting old and gray doing that. But most of what we do does not involve putting people into prison. And I think a lot of people don't understand. I noticed as people were called here coming up, a lot of you knew each other. A lot of you have associated an interaction and worked together with each other. But I don't know most of you. I've never had contact with most of you. I suspect most of you had little or no contact with prosecutors. At the end, you don't. And part of you don't understand what we do. And I think we need to, I'm going to divert a little bit, but I won't take too many long. I'll start by talking about diversion by diverting. Prosecutors represent the public. We represent the public in general. Now those the public's composed of people who lived in the neighborhoods where low-level crimes may be committed, and I'm talking about relatively low-level criminal behavior. People who go to school, people who work, people who run small businesses, people who use the parks, people who use the greens in the area where low-level offenses occurred. People who are trying to live and maintain an apartment building to rent it, where people are sleeping on the front walk or sleeping on the lawns or engaged in other low-level chronic behavior, which results in the police being called. Police may be called and tell somebody you can't be here anymore, go somewhere, go home. They have no home to go to. They come back. And ultimately the police are going to arrest them. Well, in most cases, in most states, almost every other state except Connecticut and Louisiana, I think, when a police make an arrest, it goes to the district attorney's office. And the district attorney's office makes a decision whether or not to file charges. Connecticut's different. Because of the way when the old town courts and the municipal courts and the trial justice courts were eliminated in about 1960, they created a statewide court system. And every time the police make an arrest, it gets filed in court. The prosecutor ultimately decides whether or not to continue with the prosecution, but that decision is made too late in the process. Prosecutors go, you open the door at 10 o'clock in the morning, there's 200 people lined up outside the courthouse, or 9 o'clock, 200 people lined up outside the courthouse waiting to come in when court opens at 10 o'clock. Many of them are not represented by counsel, many of them have low-level offenses, many of them just want to talk to the prosecutor. The prosecutor usually hasn't seen the file because it gets processed through the clerk's office and the judicial branch. The prosecutor's office often doesn't see the file until the defendant is standing there saying, I want to talk to a prosecutor. The prosecutor starts talking and starts reading the file at the same time, and then makes a decision. That decision is also often, I don't have enough information to make a decision. Looks like there's probable cause here, and the case goes through the process. And some of these defendants have to come back to court 3, 4, 5 times before their case gets disposed of. Sometimes they miss a court appearance, they get rearrested because they miss the court appearance and they don't come to court, they get rearrested, next thing they're in jail. Most people, most cases, do not result in incarceration and shouldn't. The things that we need to do are enable and what we're trying to do in different areas, and it's worked out differently in the program Kathy described. In New London, we've worked out something a little differently, and we're working out things differently in different areas around the state. And the critical thing here is, I think, these initiatives start locally. They get fed locally. The relationships build locally, and they have to build locally. Prosecutors need to be able to decide not just can I prove a case, but should I try to prove a case? Is it in the public's interest to prove this case? And part of the public is composed of, all of the public is composed of taxpayers. Is this something that the best result for the public is prosecution? In many chronic low-level offenders, it's obviously not. But there hasn't been any other solution. What do you do say to the store owner who somebody's been panhandling out in front of the same store 48 times? And has been arrested for 30 times for that. And customers don't want to come into the business because this guy's panhandling in front of the store every time he gets out of jail. You know, we represent that person too. And we need to find, well, what else can be done? What we care about is not locking this person up. We just don't want this person panhandling in front of the store anymore.
Kevin and I have housing providers. We have a whole array of providers. I'm sure I'm leaving some folks off. And what we really do is that community roots, advocacy, and putting together plans for folks. So these are folks that come into the emergency room often, and or any provider, and there's a consent, right? So that's a big barrier sometimes to community care teams because there's all these different providers talking about individual people. So anybody that the service provider gets to sign on to the consent as well, we can talk in the room and do care plans right then and there in the room. And then it's a collaboration outside of the room as we follow people. And so we have been successful in the legal department as well, forming some bonds and trying to get people into treatment versus incarceration. I think the other thing about a community care team, it is time unlimited. The consent does expire in a year, but as long as somebody re-signs, we've had people on our team for 4 years. So where they're failing out of housing, where they're failing out of other systems, the community care team can really be a stopgap for folks. We really can get creative in our plans and come back to the table when we need to. If they get incarcerated and come back to the community, it is definitely an avenue where somebody can pick up some responsibility for folks, and we can keep trying whatever plan we need to have. And we have that ability to reach out to those individual providers and bring them to the table. I also encourage my service providers that come to bring those folks that they're struggling with also in the community. And we've expanded in Norwalk. So where it was a part-time grant, which is how I was hired, the hospital, because it's reducing emergency room visits, because it's reducing inpatient stays, and we definitely have the data to show that, I became full-time. The hospital then took me on as a budget, and then this year we actually hired another high-risk navigator and a peer, which full-time, which is, I thought would be really a nice complement to our team, so somebody who's had learned experience that can engage in people in a different way.
So the hospital has really invested in this innovation.
Yeah, so the hospital's payment structures are changing for hospitals. So right now, to be honest with you, we're costing the hospital money. So right now you go to the emergency room, right? They bill your insurance. I mean, people say Medicaid, you don't make too much money on Medicaid, but you at least break even. But right now, as we start to see the emergency room visits drop and inpatient drops, honestly, we're costing our hospital money because they're not billing for those people anymore. But we've signed contracts. We see the wave of the future is going to be bulk payments. So the hospital's going to get X amount of money from Medicaid to cover X amount of population. But if you have that one person that's coming 120 times, they're eating that money. And whatever you save, you get to keep. Whatever you spend, you get to eat in your budget. So it becomes a, I think it's in the best interest of everybody. They'll say clinically, right, it's best to keep people out of the hospital and keep them stable and to keep the community engaged. But also there's a fiscal push going on as well.
Sure. So it should be clear to most of us in the audience where the connections are here to chronic homelessness and risk factors for chronic homelessness. We know the people we've served in our initiative to reduce chronic homelessness are people who are in the hospitals a lot, people who are in the criminal justice system a lot. I want to invite Kathy Flaherty from the Connecticut Legal Rights Project to speak a little bit to what service her agency brings. And we're thinking a bit about interventions that reduce returns to homelessness and opportunities to intervene earlier than we might otherwise. So we can talk a little bit about the Legal Rights Project and what impact it might have on reducing chronic homelessness or returns to homelessness.
Absolutely. Connecticut Legal Rights Project has been in existence since September of 1990. We were formed out of a consent decree as a result of a lawsuit that was filed against the state of Connecticut on behalf of people who were inpatient in, at the time, the 3 large state hospitals. We represent people who are in the hospital to protect their legal rights in terms of access to treatment, in terms of meaningful participation in their treatment, in terms of a right to a discharge plan, which obviously for most of our folks includes what are people looking at in terms of housing options for them. Once people are discharged and back in the community, we represent them on a host of issues, including maintaining housing, getting access to housing, which is most important to people in this room, but the other factors that go into that: education, employment, self-sufficiency, and protecting their right to choice and living in the community of their choice and doing well in the community of their choice. What I really appreciate the opportunity of these IForums is to learn what other people are doing, because everybody's serving the same groups of people. And I know a lot of our clients have had interactions with the criminal justice system, and civil legal aid lawyers don't tend to look a lot at what's going on in the criminal justice system, but it has collateral consequences for our clients, because when they come to the top of a wait list for subsidized housing, if they have a criminal record, they're likely going to get denied. One of the things that we are able to do, and we have been able to do phenomenally well, is when people come to the top of those wait lists, and the reason they're getting denied, whether it's bad credit, whether it's an eviction history, whether it's a criminal justice history, if that is related to their mental health condition, we can request a reasonable accommodation of those policies and get people into housing they otherwise wouldn't have had. When people are getting evicted from the housing that you have managed to place them in, don't just move them to another provider. People actually have the legal right to stay in that housing, and there's a process that has to happen. And what I would encourage people to do is contact us as soon in the process as you can. Because I think case managers, out of the best of intentions, intervene and think that you might be able to solve the problem because you're like, this is my client, I want to take responsibility, want to take ownership of this. But when you do something, when you don't know all the legal ramifications of what can happen, it sometimes forecloses options for us within the legal system when you call us much later in the process when the person's about to be put out of their apartment. So call us earlier rather than later. And I just want to put some numbers out if that's okay. The Commissioner of Housing talked about how it costs the state minimum about $33,000 a year if a person who's homeless stays homeless for a year. We represent about 550 people a year in housing cases. When we open a housing case for somebody, when we close their case, fewer than 1% of them either doesn't have access to housing, or they either have the access that they didn't have, or they maintain their access to housing. Fewer than 1% are homeless when we close their case. That is real data. And if only 12 people that we are not able to serve because of the cuts to our funding in the state budget, if only 12 people become homeless and stay homeless for a year, you've lost the projected savings in the budget from cutting the money that's given to CLRP to represent people in housing cases. So that's just something to think about. We are here, and we are here to help the clients we all share. But a third of our staff is laid off as of June 30th. And there's nothing I can do about that because we don't have the money to pay them. Because we have the consent decree, we have overhead that's very generously provided by the Department of Mental Health and Addiction Services, but that means cuts to funding, means cuts to staff. So we are still here, we are still active, we want to be engaged with people, we want people to refer clients to us, and we will do the best we can to serve them.
Thanks, Kathy. And when you talk about representing 500 and some folks, those would be clients you've taken on for representation. But when you talk about calling early, you may have some capacity to provide some counsel. And we'll pass the mic back to Kathy real quick. And their intervening early may be a way to have an impact even with diminished resources.
Right. When we talk about 500 people a year, that can be all levels of service. Sometimes it's at full representation in an action in court. But I will tell you, as a lawyer, the last thing most lawyers really want to do, if we can avoid it, is litigate a case. If there is a way to intervene early and solve the problem and get the person where they need to be without having to file a discrimination case, without having to deal with a summary process eviction case, we would much rather do that. And it's a lot more effective because, frankly, as long as that legal case is hanging over somebody's head, that's a cause of stress that nobody really needs, but especially if you're living with a mental health condition, worrying about whether you're going to be able to keep that house over your head, that roof over your head, is a level of stress that nobody needs. It doesn't help.
Thanks. So the next question is to Fred Morton. And Fred, you've been at CSH, you've been at DEMIS, you've been our data guru, and our HLIS guy, for any of our permanent support housing site visits. So if you could connect some dots for us. I wanted to ask you about this question of risk factors or signs of chronic homelessness that's coming down the line, where we may be able to identify people who are at risk, Are we able to do that? Will we need to be able to do that? And then once we do that, what can or should we do to target resources in response? So,
thanks, David, and thank you everybody for having me here too. DEMIS provides housing subsidies for about 1,900 people through 60 grants, and then in addition we fund about 2,400 service slots for permanent supportive housing services. And the reason why I give that background is because we've worked with CSH to develop a quality improvement initiative with our service providers. And as part of that, we've developed what we call the Acuity Index, Supportive Housing Acuity Index. And I was lucky enough last week to be at the CSH Summit, and actually Terry and I met again, and I presented about our Acuity Index. And so basically what the Acuity Index is we require all our service providers to administer it, to work with folks twice a year, to develop service plan goals, and it looks at housing stability across several domains. We look at rent payment, we look at connection to community supports, connection to mental health services if needed, income, benefits. So it's quite an interesting tool that we've developed, and we're happy to say that we're working with DEMIS's research unit, which is through the Department of Social Work at UConn, to validate the tool and to kind of see how we can tweak it to make it more useful. So I think that can be used not only for service planning, but to identify moving on, to identify across all levels where we need to target resources. So folks coming into the criminal justice system, we can kind of use that to identify where they might end up after the criminal justice system. So yeah, and should we target the resources? We definitely need to, because as we all know, unfortunately, our resources continue to shrink. So we have to really be more smart about how we're doing services, not just developing a program, but seeing, is it working? Is it is it worth it to continue this program, or should we tweak it and change it to do something else which is more effective? So yeah, we definitely should use that tool and other tools to evaluate and see where people are at.
So a lot of us are familiar with the Acuity Index as an assessment that we do with participants in supportive housing. So you have clients in supportive housing who are using that tool to track how they're doing over time in the program and whether they may be ready to step to some other level of intervention, right? Whether that's a higher level of care or more independent. But it sounds like you're suggesting you may be able to use that tool in other sectors, to discharge planning from healthcare or corrections to identify service needs.
Yes, some of the measures really dovetail well into discharge planning, into looking at where folks are at in terms of housing stability, connection to community resources, connection to mental health services, primary care, everything that really influences someone's housing stability. And even if other providers or other service areas use those categories, and I just wanted to put a plug in, I was thinking this morning, what do I want, really to say? And I think that we really need to, as a state, look more at data. Not just data for data's sake, but really, how are we measuring what we're doing? How are we strategically using data? I mean, we do great things in Connecticut across the board. One of the things that we really need to up our game in my opinion, is with data. Not just data matching, but integrated data.
Right.
And so that we can look and see what people's needs are. We can target the resources that we need. But that's a lot of work. But I think it's something that we really could do. And I think if the Housing and Homeless Services partnered with CLRP, mental health, substance use disorders treatment, criminal justice system, prosecutors, if we can come together and say we really, really need one system that we can access easily so that we can target resources to be more effective and do outcomes as well.
When you talk about data matching, that would be as in the Connecticut Collaborative on Reentry, formerly FUSE, where we had data from the Department of Corrections and HMIS, and we were able to generate eligibility lists. You're suggesting with integrated data would be something more than that.
Even if it's like a warehouse or something that we can use and easily pull out for CCT teams, for DOH, DMIS, CLRP, DOC, CSSD, all the acronyms. All the acronyms get together. But I think that, and in addition to, not to hog the mic, but like what Terry said earlier, is that to realize that as housing and homeless service providers, we have our feet in many different countries. Same thing with hospitals, same thing with criminal justice, same thing with CLRP. So we really need to learn locally what's out there, make the relationships, build the relationships, go to a court and ask to meet people. So there's a name to the face, and so that we can make our priorities of keeping people housed or keeping people off the streets their priority, and vice versa. I mean, we don't court folks don't want to see people come through the court. So how can we deal with that? How can we do outreach so that if a police officer gets a complaint that someone's panhandling, how can we assign outreach teams or mobile crisis teams or somebody to go out and talk to the person and try to motivate them to move on from that area so that that person doesn't even get pulled into the system as well.
Sure. That's a good segue to my question for Steve. So we've heard this morning about some investments from hospital system or from the Ohio project where the Department of Corrections and the prison system are investing in permanent supportive housing. So I want to know, how can we sustain our homeless response system's current mission and focus while we encourage or expand collaboration with these other systems from healthcare to criminal justice?
Sure, so I think that's one of the things that I've learned in our efforts to end all different forms of homelessness, including chronic homelessness. I think the great progress that we've made has been due to collaboration and coordination, and it's really about looking at your silos, looking at your barriers, and kind of breaking those things down. Obviously, it's been talked about how everyone needs a village, but they need to be a community too. We need to be able to break down some of these, institutions that, prevent us from working together. So how best that we can do that. And when you look at where homelessness has come from and where supportive housing has come from, it's all been about interagency partnerships. We have our interagency committee on supportive housing, in which there are 10 separate agencies that sit together on a monthly basis. And now we are speaking the same language when it comes to homelessness, and I think that is really effective. But we still need to push that out because that is only 10 agencies and it is only about a handful of people. So how do we engage more people within those agencies to really understand the issues that are shared amongst the individuals? Because that's what we do know. We know that there's one person that crosses multiple different systems. So how do we look at our agency regulations? How do we look at our federal funding? And really streamline some of the services that we do provide so that we're able to take an individual that comes in from each of the different separate agencies and work together in order to be able to provide them with the proper resource. If it's housing, that's great. If it's treatment, that's great. If it's some sort of special probation or parole, we should all be working together on trying to mitigate, each individual case. So how do we look at, in a coordinated fashion? And I think if we do that, we're able to really pool our resources, because as a time that we're, in this difficult situation, we have to look at what we do have and how do we use it better, how do we use it more effectively, and how do we use it more efficiently. And I think by being able to speak each other's language, by being able to work together, we can actually get to this and use our funding in a way that is more effective. We need to look at our outcomes. We need to start thinking about having shared outcomes. What is the base that we all want to see? We all want to see somebody who's stable, living in the community. So that's our ultimate goal. How do we get there from each of these different systems? And how do we use the funding from each of these different systems to be able to get to that goal? So that's something that I'm certainly interested in. I'd be willing to work with any partner in order to look at that, and how we can break down those silos, I think, is really the key to moving forward in this time.
Thanks, Steve. So drawing on that, I want to ask Dr. Maurer and Kevin Kane. We've heard a lot about collaboration. I think early days of collaboration can be tough. You've had a lot of success in Bridgeport, looking now at New London. Could each of you speak to what makes for a successful collaboration at the outset, right? If we're looking forward to new opportunities to collaborate, to bring partners together in current budget environment, I think a lot of us may be feeling protective. It may need that extra little bit of reassurance that a collaborative effort or reaching out to new partners is not going to eat up valuable time and resources. So what would be kind of ingredients in the recipe, as it were, for a good collaboration? Go ahead.
So I think, first of all, I think you have to have a common interest and common need, right? I mean, the criminal justice system, Kevin has a certain interest in these patients, and he would like not to put everybody in prison. We have a strong interest in that. Also, I think it makes a difference. You come together with a certain amount of integrity and ethics and trust. And I think that's what makes partnerships really work. It took a long time. It took 6 months to get this program together. I mean, Kevin and I had been working together more or less off and off. Hey, Kevin, this is a really sick guy. Can you do something to get him out? Well, I'll try. Remember, I mean, we'd been doing that for a year or two or more prior to when this happened, prior to starting the project. But the fact is, it took about 6 months, and it took people believing in one another and the willingness to, there's risk in this, okay? Sure. Any of this stuff is risky, especially in the criminal justice system, because there's always risk involved. And you just really have to have a solid foundation of trust among people who are working in this area.
And Kathy really started it. She came to me with an idea one time, and I said, Kathy, she had a good service provider down in Bridgeport, and I said to her, why don't you go down and meet with the prosecutors in Bridgeport? Start with the prosecutors. I didn't go deliberately. Brian Austin went to facilitate and observe it, and Kathy went down there and met with the prosecutors, and it was as she described. At first she started talking, and the normal reaction from prosecutors, including me, is we're not social workers. And Kathy started, and within, I don't know how long, half an hour, all of a sudden people said, wait a minute, we're not social workers, but these people have social problems. That's the solution. Jail's not the solution. Making them come back to court many times isn't the solution. We can get in the way. But imagine this. Think about this. And somewhere in this country it's done. I keep thinking it's Rockford, Illinois, but no matter who I tell it's Rockford, Illinois, they never come back and say it is, so I don't know where it is. But imagine this. Take Norwalk for an example. Norwalk Police Department now used to be anybody who's arrested went on the police blotter. Handwritten blotter. I don't know why they called it a blotter. But it was available at the front door of the police station. Anybody could come in any time of day. Who was arrested last night? Who was arrested this morning? It's public information. Now all the police departments have converted, and they have electronic record management systems and data systems, and we're on the verge, believe it or not, in the state of Connecticut of getting it for prosecutors. I've been hoping we would get this since 2008. I think my dream is we're going to get it. I don't think I'm going to live quite long enough. But I think we're going to get it in the next couple of years. We're really on the verge of it. Imagine if the Norwalk Police Department arrested somebody, and they could send out a notice to all the service providers, public information. Immediately send out a notice to all the service providers, Norwalk Hospital, Steve's agency, other agencies. They'd get that notice within an hour or two of the arrest, maybe even earlier. Maybe even the person would be still in custody of the police, where the police are deciding what can we do with this person, do we need to put a bond on him? Maybe somebody could call up and say, that's Joe. He's been with us. We know where he's been. We know he relapsed, he this and that. Imagine what could happen at the very beginning, how things might change, and how much cheaper it would be to do that. Imagine what happens after you get, the reason it started with Kathy is she came to me with people who were on a drug maintenance program for drug abuse. Heroin addicts who are being treated with methadone, they get locked up for a relatively minor offense, maybe not too minor, but maybe relatively minor or not important. They get locked up. Now they're incarcerated for 2 weeks, 3 weeks, 6 weeks, a couple of months, and they haven't had their methadone or their drug, and they come out and now their addiction's back full-fledged. That's what's happening. How can we deal something up front before that kind of thing happens? And it doesn't just happen with drug addicted, it happens with mental illness, homeless, a whole variety of people who are causing these chronic low-level offenses, where if you could get immediate notice and get contact, the police could then, somebody, the providers, could call the police department right away, or come to the prosecutor's office 2 weeks before the court date, or 4 days, or a day before the court date, and say, you know, there might be another option for this person. Do you really need to prosecute? Maybe it's the kind of crime we have to prosecute. Maybe there was an assault or something where there's a victim or a robbery and there are robberies and robberies. I mean, that's why you need to look at individual cases. But coming in first might give us another option to say there's a better solution to this problem than prosecution. Imagine that, instant notification from the police, which they have the capacity to do that. Every police department has an electronic record management system now. This kind of thing is going to start locally. Go to the police department and give this idea. And see if somebody thinks of it. The idea, the motivation is going to have to come from you folks. A lot of things I say go on deaf ears. And say, who are you? You just put people in prison. You want more help doing that. Well, that's not what. But try something like that.
Sure.
And that begins the communication. But it's all communication, and it's all on a local. Law enforcement problems are local, not just in the town and the city, but in the neighborhood, where people live or congregate or commit their crimes or use or live or go to school, whatever. And the contacts have to arise locally. You don't need to look to Hartford or Washington or the capital to, the beginnings of those contacts have to arrive locally, and the motivation has to arrive locally. You can't wait for Hartford or Washington to do it. But you can do it locally.
So we'll do a brief question to the rest of our panelists. I think the point about public information that we're already able to work with is well taken, because there are a lot of naughty questions here about releases of information and confidentiality, which we can read into another time. But very quickly to the rest of our panelists, and then we'll have time for Q&A, I wanted to ask if we were to identify one key thing that our homeless services providers have that they can bring to the table in a collaboration with other systems. What might that thing be that you'd ask them to bring into a collaboration?
The one thing I'd really ask as you're starting any kind of new efforts or even continuing efforts you've already started is make sure you involve the people who've received services from the system, the people with lived experience. I'm thrilled to hear you've got a peer involved in your community care team. Because those of us who have the experience of being treated in the mental health system or being homeless or being in the criminal justice system, we can tell you what worked and what didn't work. And it's very easy as an attorney to sit at a table with a lot of other people and a lot of other professionals and come up with things that I think are fantastic ideas that would be the solution to all the problem. But if I haven't lived it or I don't have the input from people who have, as to whether this great theory that I've come up with is actually a good thing, then I think I'm failing in my job. And the other thing I want to point out really quickly, because I forgot, is CLRP is not the only legal services agency that serves our client population. We have legal aid organizations all over the state, and we collaborate with each other too. So CLRP is a part of that puzzle, and we're all really here to help our clients do better, so thanks.
Fantastic, thanks. Fred?
I think we need to talk outside of our comfort zone more. I think that we do in the housing homeless services world, not so much the providers at the ground level, but us at our level here. We talk too much to each other, and we need to pull in more other folks to figure out what's going on, how we can work together, how we can pool resources. So I think that's one thing is for us internally to kind of cast the net wider and see how we can support other efforts, how we can use resources like CLRP, CCT teams, how we can come up with plans. And again, with data and combining data, I have a great idea in terms of if we have all one data system and like what was said, comes up and a ding and it goes to the provider where a person's active. There's no release of information needed because it's public information, and it pops up on my screen that a person that I'm working with or my staff is working with has been arrested. There's no need for the courts or police departments to know that that person's in treatment, but if we combine it, and that's an easier way to do it. So that's just my mission.
Got an app forthcoming. Yeah.
I don't know. I won't be around to see that. So.
Stacy?
I mean, I think we've had great partners with our homeless providers. I do think one thing that it highlights is, I think sometimes the service providers need to know what other service providers do. So, and they need to, even though you want to speak the same language, you have to understand where other providers are coming from, because everybody has a certain stake in what they do. I definitely think housing is seen in the legal department and medical and substance abuse. I've talked to many inpatient programs. It seems so vital to people's relapses, incarcerations. Those providers want their folks to get housed. They don't necessarily understand how the housing system works. And so I think a lot of education from housing providers and homeless providers are really important. But I think also for those providers to get out of their comfort zone and reach out to the other providers. You need to understand how to work with medical providers. You need to understand how to work with attorneys. You need to understand how every little piece fits into the goal for that particular client and be effective in that. And sometimes that's taking off your housing hat and understanding it from somebody else's perspective so that you can kind of, get them to work with you more effectively.
Bring that person-centered approach into all of our work. Steve?
Yeah, I just kind of want to build on what Stacy said there. I think our experience in the last couple of years with the coordinated access networks really shows that providers that are on the ground are willing to, take off their hats of this is my agency and really look at overall what is good for the community and what is good for the individual. So I think we've been able to do that on a small scale, which doesn't seem so small for the homeless providers to accomplish some of our goals. But now we need to take, what Stacy just said is the next step. It is to be able to reach out to the criminal justice world. It is to be able to reach out to the medical world, because I think those really are a couple of great partners, a couple of great potential feeders to the overall system. And if we can engage them early on, we can prevent a lot of the long-term harm that is done to individuals as they cycle between systems, as they fall between the cracks. So I think we've been able to do this on a small basis, and I think now it is time just to take the next step. And then we can really start looking holistically at the person's, in a person-centered way to really understand where they're coming from and how we can really, work with them individually to get them where they need to go.
Great. Thanks very much, Steve. So I know we've got a few minutes for Q&A. I think I've got Cindy running around with the mic.
Dr. Maury and Kevin Kane, you spoke about efforts to have diversion of persons once they get to the police department before they get too deep into the criminal justice system. About 20 years ago, I think the the School of Public Health at Yale and the New Haven Police Department had a program that they were testing to get that information even before to the police officers on the street with cards of information of places they could divert people to before they even got to the police department. Is that still in effect? Is that still a possibility, especially given the electronics that are now out there?
It is still I don't know what happened to that program in New Haven, but it started, the theory and the idea was good. There is an effort now, particularly in Hartford and I think New Haven, to start what's calling a police diversion program. There's been a big grant from the MacArthur Project to those areas, which are allowing police to find alternatives to arrests through contacts like that. It's trying to be monitored. It's something that's a small portion of the grant. Most of that grant went to dealing with people as they come out of prison to try to get more people out of prison. But that's a good concept, and it might work well locally to give police knowledge that maybe they don't have to arrest this person. One of the things that happened in New London that started out, a lot of variety of things happened in different areas, was the crisis intervention program, where the police would get called. A, they weren't learning how to recognize people who were going through mental health crises. B, once they did, they didn't, they take the person to the emergency room, but instead of describing the things that the doctors wanted to hear, they're describing how the person kicked out the windows of the cruiser, and the crimes the person committed, and the doctors are saying, we don't want this person here, get him away. DEMA started a ride-along program, and after training the officers involved and the dispatchers to recognize the mental health crises, DEMA's had somebody who would go along on a ride-along with them, and sometimes they'd diffuse the situation, there'd be no need for an arrest. Other times they'd go to the hospital, and they would describe, the DEMA worker would describe the behavior to the hospital, and all of a sudden these people were being committed rather than sent back to the police station and being arrested and going to court. So that concept is really good. I think it died out in New Haven. Who knows why? I don't know. But it's time to grab a hold of that and get it done again, if you can. It would be terrific.
Fred, do you want to speak to
that?
that?
I just wanted to say, I mean, we still have, DEMA still funds CIT programs throughout the state in different communities, and oftentimes it's a clinician that goes out with a police officer, also training the police officers to kind of do mental health first aid and other supports as well. So that's a good idea about a collaboration between two systems and how each individual system has the shared goal, which is basically safety. And now Cable, which is the private nonprofit which organizes the trainings, they're also kind of looking at mental health for officers and first responders as well, and realizing that we need to care for our first responders and give them assistance as well. So.
Great, we have another question here, unless someone else from the panel wants to.
Hi there, Kevin. This is Hyacinth Yenny with the Maple Avenue Revitalization Group. And as a community leader, we dealt with a lot of issues. You talk about, the panhandlers, the people who stand in and claim they're homeless and stuff like that. And we continue to have our monthly meeting, and our residents always complaining, why can't the police do something? Why can't the justice system do something to prevent all these things from happening? And I'd like to know, how can we bring this out more into the community? Because just like how we started that community court in our community to address small issues, we need something, we need someone coming out to our community to talk to our resident about how, what's really going on and how we can address this, whether the court or local, prevent arrests. So can you help me in any way with that?
Sure I can. I'd like you to, there are people in the Hartford State's Attorney's Office. Tom O'Brien is a prosecutor in the community court. He goes out and does become engaged with neighborhoods, which is a good idea. But I think it would involve reaching out to the Hartford Police Department and somebody from the Hartford State's Attorney's Office and getting them to come to a meeting and talk. Because this is a problem that you see when the residents then stop calling the police, or if the police get called, case gets prosecuted in court and nothing happens. A lot of these low-level offenders are not going to go to jail the first, second, third, or fourth time until finally they come back so many times that what else are we going to do, send them to jail? The trick is to get somebody involved up front and find out how to deal with the problem at the beginning, before there's an arrest. And that's where it takes community engagement with the police and with the prosecutor, the local prosecutor too. If you give me your card, and I'll give you a name to call, or I'll have somebody call you, and
I'll work with Brian.
Maybe Brian will help you out. I'm glad you asked. This is what we need, is getting, prosecutors represent the communities. They need to get engaged with the communities and the people to be able to effectively represent them, your youth.
Thank you. How does leadership play a role in fostering collaboration? Who steps up and who can most productively step up and champion cross-system efforts?
Anyone? Kathy?
So, first of all, without leadership, you don't get anything done, right? And I think the way, to be honest with you, I think the way we put together the TPP program was really interesting, because we went piece by piece, little by little, and just put support together, and finally the project happened. And I have to say that leadership requires risk. And so you have to be willing to put a foot out there and get it stomped on, which was sort of happening with the prosecutors, right? Right. But then, you know what, these junior prosecutors stepped up and it was like, oh my gosh, what can I say? Anyway, that's kind of I don't think you can do this stuff without somebody who's willing to take some risk and to get stomped on. And maybe you're not the most popular person in your agency. What can I say?
I should have known you'd ask that question, Deanie. You know, maybe leadership can help most by getting out of the way. And I mean that. I mean that. It starts, the people in the prosecutor's office, when Kathy went down to talk to them, it was the younger prosecutors, and some of the older ones got it after a while. You get cynical as you're around people. The younger ones got it, and then quickly the older ones said, you know, this is what we do. These people need help, not us. And they're recognizing that. And that's why I think local problems start out with local solutions best. And that motivation has to come locally. And it's all around, and the desire to do it is all around. And one of the problems is people look to the leadership to solve the problems. And the leadership's best sometimes standing out of the way and providing the engagement, encouraging people to get engaged.
And Kathy, we've got about 60 seconds. Do you want to speak to the question as well?
Yeah, I think the important thing is that the leadership and the message has to come from the top. And I think coming into a system in this role in Connecticut where it's very clear from the governor on down and through the various agencies that there's a commitment to breaking down those silos and looking at the problems holistically. I think Fred and I were talking a little bit before we started. The thing that's really important is if you just have the one designated point person at that agency and then that person moves on, is the relationship gone? How do we establish the relationships between and among providers and agencies so that it doesn't rely on one particular incredibly charismatic person to be in a role for things to continue happening?
And
we're going
Cindy,
to allow for one more question, and I'm sure if there's other folks who have questions, the panel will be, I'm sure they'll stick around for it. So we're sitting here thinking we haven't heard anybody talk about jobs or employment, and it's all very related to housing.
I mean, to the extent that we don't, at CLRP, we don't help people get jobs, but one of the very real problems for our clients is if they have to disclose their disability at a job, they get discriminated against. And it's remarkable to me when employers can get tax breaks for hiring people with a disability that they resist that. But I do think it shows how we can't look at any of these problems in a vacuum.
Stacey,
yeah. I think employment is really tough with this population. Saying that because I worked in New York City on an ACT team, which is like an assertive community treatment team, and we had a supportive employment specialist, and I was a real big advocate of supportive employment. And when our population, I saw how much we struggled with that as the director of that program. That being said, at our community care team, we do actually, one of our primary care has an employment specialist coming once a week, and I really liked that model. And so when the person comes, and it's actually an integrated primary care, which is even a better model. So you get your mental health treatment and your primary care right there, and then they can get referrals right then and there for the employment. And then they're able to collaborate as a system. I definitely see the role of employment. I think some of the folks that we house, right, they have nothing to do all day. They're lonely, they're out of their system in the shelter, you're hanging out with your buddies, and now you're by yourself. And I definitely think that is an area that I see as missing in our community. I think a lot of case managers don't know how to do it. And I do think it takes a particular skill set and a philosophy to be able to do it and have some realistic expectations.
Yeah, I just wanted to second that. Employment supports recovery in mental health. Even if folks get a housing subsidy and assistance, it's still very, very difficult to live on Social Security. And just for quality of life, I mean, every single study that's been done with supported employment has shown that it promotes recovery, that it promotes stability, it promotes, not recidivating, and it's just across the board. I think it's just something that we struggle with in the economy, and it would be great if we could have, local, DEMAS does fund supported employment for folks with mental illness. So accessing that system, trying to access that system. But I think overall, just for folks involved with criminal justice, homelessness, across the board, if we could get supported employment specialists who really cultivate an employer network, because that's shown to be key, and help people to make those connections so that they can work and get a job. It's really pivotal to what we do. So,
thanks. And I know DEMAS and DOH are looking at how to foster more collaboration on the state level with DSS and with our Department of Labor, and go ahead and reach out to your providers locally and see what you can get started following Kevin Kane's advice, because the knowledge base that we'll need to make those collaborations work over time is going to come from that level. Cindy, do you have anything else?
I want to thank our panel for being here today and our moderator, David. Let's give him a round of applause. I also want to thank all of you for coming to today's IForum and get geared up for our next IForum series next year. And coming up June 15th is our Reaching Home Awards dinner, so we hope that you will come and join us at that event. And thank you again.